Okay, hello everyone. My name is Bob Brucker. I am the founder and president of AgeWise Colorado, and Barbara Boyer is our executive director. For those of you who just joined, you probably heard Barbara speaking a bit. I'm going to show you a quick slide of for us, just to get this in front of everyone. So we are AgeWise Colorado. We're serving aging Coloradans and the caregivers of today and tomorrow. There are 3 million people in Colorado who fit that description. And we are currently seeing around 6,500 people visit our website every month, which is a huge increase from last year. So we expect that kind of progress to continue. Okay, so now I'm going to stop sharing here so that Fred can pull up the Care Synergy slides. So we're visiting with Care Synergy. So we have Dr. Kristen Keefe, who's going to be doing most of the speaking. She's the Care Synergy Chief Medical Officer. Mary Beth Savory is the Care Synergy Clinical Outreach Administrator. And Fred Hobbs is Care Synergy Director of Marketing and Communications. Care Synergy is a nonprofit network focused on support for older adults and several other things. And so I'm going to turn this over now to Dr. Keefe. So take it away.
All right. Well, what a pleasure to be here today and speaking with you. Um, just a little bit about my background. I'm a gynecologic oncologist. Really, my roots are in New England. Studied at Dartmouth Medical School and then did my OBGYN residency at Mass General and Brigham in Boston, and then 4 years doing my fellowship in GYN oncology, and then practice as a GYN oncologist in Boston. And in my career, I really recognized over and over again the need that patients and families have to help them make complex decisions in a really dynamic healthcare system. And if anybody's been in Boston, Brigham, Mass General, Dana-Farber, Beth Israel, they've taken various forms over the last 20 years. So, complex decision making, and really, I devoted my career once I became a palliative oncologist to helping people with those decisions, but also helping people manage symptoms so that they would do well during their treatments. My travels, once I started palliative oncology, I started developing systems across the country. So I started in Boston. I went down to the Seton Family of Health down in Austin, Texas, went out to Sharp Healthcare in San Diego. And then I was there from 2015 to till January, when I came to Care Synergy as their chief medical officer. So when I was thinking about what I would say to you as a GYN oncologist, my scalpel was my tool. And as a palliative care hospice physician, the conversation is the tool, and words matter. And there's a really great book by Rabbi Joseph Telushkin that is titled "Words That Hurt and Words That Heal." So the whole goal now is to help everybody live as independently as possible. So next slide, please. Oh no, keep it here. So today, that's what I'm going to talk about, is how do you preserve your autonomy? Um, and this is difficult to do. Financial constraints. I mentioned the dynamic healthcare system. You don't really know who to get help, how to get help all the time. Actually, what I observe pretty frequently or hear from patients and family is they actually don't even know who's in charge of their health care. The nuclear family is challenged. Our children are all working. And of course, as we season, like myself, I don't want to be a burden. So next slide, please. So So, what's important to all of us, we all want to be in control as much as possible. And what does that mean? We want to think clearly, stay active, accomplish our activities of daily living feel safe and supported. Um, we fear, I fear, and I hear the fears that people don't want life to come full circle. We're born dependent. We learn our ADLs and our IADLs, and really we want to slow down this process. I think the biggest piece of advice I can give to everybody is the body keeps the score. So as we season, pay attention to what it's telling you. Don't pretend you're 40 when you're 70. And naps are okay. So why care synergy? Next slide, please. So care, yes, thank you. Care synergy. I came here because it's a non-profit regional network of hospice and palliative care, home health, and aging services. And sometimes this concept is challenging to understand, but it's really best understood as not as a single provider, but a platform or integrated delivery network for community-based serious illness and aging services. So the major service categories that Care Synergy offers is hospice care, palliative care, home health care, the PACE program, which is the program of all-inclusive care for the elderly, Capable program, which helps people age in place, durable medical equipment, and bereavement and caregiver services. Our geographic footprint is 5 places: Denver Metro, Aurora, Northern Colorado, including Fort Collins, Wells, Larimar, Colorado Springs, Pikes Peak region, and the Broad Front Range counties. Fred, go back to the previous slide. I wanted to say one more thing.
Sorry about the.
You can't, well, let me just say one more thing that I feel is really important as we approach wellness and prevention is that what we really need to do is maintain mobility, medication management, prevent falls. And a fun, fast fact that I wanted to share is about medication management in polypharmacy. Greater than 5 medications. So everybody think through your own medication list or pill boxes. More than 5 meds put someone at risk for falling. Falls take us to the hospital. It also decreases our cognitive function. Okay, Fred, thanks if you could advance to the good news. All right. The good news is that there's help. And we're going to dive into the programs that will help you get the right care at the right time so we can maintain control and preserve our autonomy. Next slide, Fred. So let's start with preventative wellness services that we offer through our relationship with the Colorado Visiting Nurse Association that actually started in Denver in 1889. What this wellness services includes is support in offering flu clinics, wellness clinics that review health history and assessment, medication review, blood pressure, and education. But one of the really coolest things about our wellness clinics is the foot clinics in the care of our toenails. So why is this important? Next slide. It's important because our feet actually tell the story. Why? Because people at risk for specific diseases, heart failure, hypertension, vascular disease with blood flow abnormalities, diabetes, which causes that, one of the things that causes our blood flow abnormalities, and the neuropathy, it picks foot care and inspection picks up infection. And why is all of this important is because we want our mobility and we want to stay healthy and happy and as active as possible. So with our wellness clinics, it really speaks to seniors Kaiser patients, that's one insurance for, or there are different insurance plans, and also there's a self-pay program for non-Kaiser patients, which is $55 per session. Next slide. Moving on to the Capable program. This stands for Community Aging in Place, Advancing Better Living for Elders. It's an evidence-based program developed by Johns Hopkins School of Medicine. Originally, we were one of 7 sites, and now it's expanded to approximately 30 throughout this country. Why? Because evidence shows that it reduces functional impairment and disability in falls. It reduces hospitalization. It helps address healthcare disparities. It's grant funded, and CMS has just approved it to support this program as part of Medicare ACO programs in 2028. So how does this program work? It's like a train the trainer program where they use motivational interviewing, active listening to help set self-prioritized goals. It's a structured, home-based program that's an interdisciplinary model, and it combines visits from nursing, occupational therapy, and a handyman to come in and make home modifications. Next slide. This handyman does a variety of things: grab bars, lights, anything, looks at rugs, makes daily tasks easier, really instills confidence in someone that's participating in this program. So who's eligible? So I mentioned earlier that we really want to maintain our autonomy, our independence. So when that RN from this program goes into your home, what they look for is difficulty with greater than one of our activities of daily living. So just defining those activities of daily living includes bathing, dressing, toileting, continence, feeding, and transferring. The next eligibility criteria could include someone with difficulty with their instrumental activities of daily living. And what do we mean by that? It addresses taking medications. Are we filling them correctly? Are we getting refills? Do we need pill boxes? Finances. Most importantly, now it helps recognize scams for the elderly, which are pervasive. The nurse will evaluate, is this person able to pay their bills, balance their checkbook? Transportation. Can we negotiate our appointments? Can we get there? Are we driving safely? Do we use communication devices effectively? Cell phones. Do we have lifelines? Can we shop? More importantly, can we carry our groceries? Can we prepare our meals? What can we do around the house? All of those instrumental daily activities of living are so important. So the criteria, just to sum up and add a few more points, are difficulty with our ADLs, difficulty with 2 or more of those IADLs, being able to live in the community, being safe in the home that you live in, and having a willingness to participate. So what's the typical profile of a patient that enrolls in the Capable program? Usually it's our seniors with functional decline that may have home safety concerns, that are at risk of a nursing home placement, that are high risk for falls, that maybe has had a recent hospitalization. The Capable program in that interdisciplinary model with that nurse, the occupational therapist, and the handyman is a program in which you enroll in for 5 to 6 months, and it's free because it's grant funded, and eventually CMS will support it. So let's move on to the next program, Colorado PACE. This is another one of our programs, but we're actually opening up another PACE program in Pathways in the late fall. So again, the PACE program is an all-inclusive care for the elderly program, Medicare and Medicaid integrated care model designed to keep frail patients at home, living in their community rather than in nursing homes. To participate in this program, there are 5 criteria. You have to be 55 years or older, which I'm already way beyond that. So I guess I could enroll. You have to be living in an area that services PACE. There's a level of care requirement that the state requires where you need a nursing home level of care, meaning you are having some functional impairment, so challenge with your activities of daily living. There may be some cognitive impairment, maybe some dementia, multiple chronic conditions. All of this puts you at a high risk of institutionalization. The fourth of the 5th criteria is community safety requirements, in that you need to be able to live at home in the community utilizing PACE services. And the 5th one is the financial program enrollment requirements. It's a capitated program where PACE controls all of the center services, which I will describe in detail next. There is a private pay option, but participants in the PACE programs, which is really a fabulous program, understand and agree to that the PACE program really now controls the finances to deliver the services. And the reason why that's significant is I'll list the list of services, and that will speak for itself. So the PACE center services, and I've been to the one in Aurora here, which is a fabulous, fabulous building with so many services that include the following: primary medical care, nurses available, social works available, physical therapy, occupational therapy, speech therapy, recreational therapy, nutritional counseling, personal care, transportation, and meals, all on site. So I met everybody and it was fascinating, but there's more to this program. This all-inclusive program is home services. They do home health care, personal care, chores in your home for you, other specialty services that come into the clinic on defined days during the month are things that we all need: audiology, dentistry, optometry, and podiatry. Furthermore, the medical director, who I work closely with, sees patients in the hospital if they're admitted, in the nursing home, and integrates their experience that just occurred with the PACE program and with inpatient specialists. Other medical services, it almost sounds too good to be true, but this is actually a reality. Other medical services include prescriptions, lab tests, procedures, radiology services, emergency room care, medical transportation, and escort. So you can see why it's an all-inclusive integrated model of care. Insurance status options: Medicare eligible, Medicaid eligible, dual eligibility. That's actually the most common and helps really with health disparities. And then there's a private pay option where there's a monthly premium. Next slide. Palliative care. So that's what I've devoted my life to. And I'm going to begin by saying that all hospice is palliative, but not all palliative care is hospice. In fact, most of it is not hospice. And the definition really is palliative care includes that complex decision making and expert symptom management that help people get through their treatments, and it can be given in line with curative treatments. So when I worked in Austin, Texas, I was on the trauma team, and we had people come in. They needed me for a short period of time. Their families needed me for a short period of time. And then they were able to progress through with physical therapy, occupational therapy, other interventions, and they didn't need me anymore. In my cancer world, there are cancers where I got them through their radiation or their chemotherapy, their immunotherapy, their targeted therapy, and their symptom burden was controlled. And then I stepped out of the picture until they needed me again. I spent a lot of time dismissing the fears of opioids and how useful they are with dyspnea, with people with pulmonary disease, pain from tumor burdens, vascular disease, diabetes, because that's a big fear right now in this country. It actually has been for quite some time, but opioids are extremely helpful. In fact, when someone comes into the emergency room with a myocardial infarction, the first thing we do is give IV morphine, which is way bigger doses than we give in a clinic setting. There's fears of addiction that really that's a psychological thing. It's not really the patient population, but if someone does have addiction misuse, then we treat that as well. So I'm going to take you through a goals of care discussion, and I hope everybody when I take you through this, this discussion is something I use to get to know my patients, to understand who they really are. And it comes from something called Start the Conversation, and it was written in Vermont. In one section of it, there's quite a few, but one section is entitled, Are Some Conditions Worse Than Death? So I'm going to take you through some of the questions that I would take everybody through goals of care when they're well, actually, when I'm helping them get through treatments, but to really understand and help enable them to make decisions for themselves in decide what interventions, what they want to do, even down to their medications. Because as I said, more than 5 put you at risk of falling and can impact your cognitive abilities. So what if you no longer can walk, but get around in a wheelchair? Is that a condition that's acceptable? What if you could no longer go outside and you had to spend all day at home? Is that acceptable? What if you could no longer contribute to your family's well-being? What if you were in severe pain or shortness of breath? What if you were in discomfort from other reasons? Nausea, diarrhea. What if you needed a feeding tube to keep you alive? What if you were on dialysis to keep you alive? What if you need a breathing machine to keep you alive? What if you needed someone to take care of you 24 hours a day? What if you couldn't control your bladder or your bowels? What if you needed to live in a nursing home? What if you could no longer recognize family or friends? What if you needed to be sedated to control your pain? So these are questions that we want to be asking ourselves and sharing with our families when we're well. Often in the hospital setting, these conversations haven't taken place, and we're making really difficult decisions. Families are making difficult decisions for us. So back to wellness, palliative care, helping people age at home, no matter where you are. So the trajectory of life is one of quality, and we preserve your autonomy at the same time. Next slide. So next slide, Fred.
All right.
So, oh no, sorry. So bringing it all together. Our goal at Care Synergy is to help our aging population when we're well, to help them remain at home, to empower them through all these programs, to be available, to have these discussions. Final slide. So now I'll open it up to questions. I covered a lot in a very brief period of time. And I'll pause there. Thank you.
All right. Thank you very much, Dr. Keefe. And we do have one question in the chat, and then I have several myself. But yeah, and please take note of the contact info here on this last slide for anybody that would like to reach out and get more information later. So we have a question about are capable and the Colorado PACE programs available in Eagle County, Colorado?
So Mary, so you're going to laugh at this. Actually, if you could see behind me, there's a map of Colorado because I've only been here for 2 months and 2 weeks, and I really don't know the geography as well as I should. So I'm going to let Mary Beth and Fred answer that question.
Okay.
So Eagle County is what we do when the service area is distant like that. So our affiliates covered the Denver metro area. So that's that big area between essentially Monument and all the way up to Longmont. And then south, it goes from Monument all the way past Colorado Springs, not as far as Pueblo, but to the south. And to the north, it's that Denver metro area all the way up to, like I said, Longmont. But our northern affiliates cover Greeley and Fort Collins. And so Eagle County is quite a distance from the metropolitan area, from the Denver metro area. But what our philosophy is that we tackle these on a one-by-one basis. So it kind of depends upon what the care is requiring and what the support would look like. So if we could, make social work, nurse practitioner, physician, nurse calls because of that distance to where all of our providers live, then we say, let's take this patient on. If it requires, something where where our staff actually has to visit the person in their home, we make those decisions on a one-by-one basis. Does that make sense?
Well, yeah, I think it makes sense. But bottom line is there's no PACE program that you're aware of itself, physically located in
In Eagle County?
Eagle County.
Not to my knowledge, no.
Okay, or Summit County, or either one, or even maybe even Mesa County. But
Not to my knowledge.
The other
okay.
thing about the Capable program is that, by 2028, we're really in a situation in our country, as we all know, that we're building networks and accountable care organizations. And so the Capable program will be taking on a new name called RISE. And there's reasons that I don't need to get into why it's taking on a new name, but I think that that's going to be more available to people in different places that we couldn't reach ourselves right now.
Okay, thank you. A question about the financial side of all this. So, particularly with Capable, how is that actually paid for? If you said it, I missed it. But
It's grant funded. So right now, this Johns Hopkins nursing school it started from, so we now fund it through grants, so it's really free. That's the bottom line, believe it or not. So I know.
I would say the only caveat to that is meeting the criteria.
Yes.
For the program, but this was all developed through the nursing school at Johns Hopkins, and so it is being embraced nationwide. And so that beginning of a program like that, it starts with the grants. So if you know of patients or you yourself would be a candidate for that, those are this is the time, right?
Mm-hmm.
Because we have the funding.
Yeah, it's a wonderful program, to have the handyman, the nurse, the occupational therapist come in for 5 to 6 months intermittently to instill confidence and do a lot of assessments of your home and your healthcare, your medications.
Now, you did mention though something earlier about CMS and capable in the coming year anyway, like 27 or 28, I think it was.
By 2028, right?
Yeah. So there will be government funding available for capable at that
Yes,
time.
yes.
In the
Yeah.
meantime, it's just the grant funding. Okay.
Yeah, and the evidence is just striking, or the government wouldn't agree to pay for it, right? So,
Yeah, I'm sure it is.
yeah.
Uh, a question about your comment about feet earlier.
Uh-huh.
So, what are warning signs that people should look at when they look at their own feet and say, "Hey, I think I need to get to a podiatrist," and you've explained, all the reasons why that's really important,
Yeah.
but I think it's something that gets neglected by most people.
Oh, yeah.
Um,
Yeah, I almost wish I could be a podiatrist because of my surgical background. I'm like, I really want to take care of your feet, but what do I look for when I'm doing an exam? Well, numbness. So diabetes, for example, the way the pathophysiology of that disease is sugar deposits in the small vessels that either go out to our fingers, but really we see often issues in our feet. And so people will start having decreased sensation, numbness. And so they'll be wearing shoes that don't fit, but they don't know they don't fit because they can't feel that their shoe doesn't fit. So then they get open wounds, they get infections. So that's a perfect example of something to look for. Are you able to feel your skin? Is there discoloration? Is there looking at the toenails? I mean, as we get older, our nails get thicker and they actually grow into our skin, and then we get infections called cellulitis, which can spread. Um, People with vascular abnormalities for other reasons, um, even cardiac, for example, you might get up and start walking and the blood flow isn't as great. You might actually experience pain in your feet, but also in your calf. So pain in your calf, so your feet while you're walking is called claudication. And that tells us that there is vascular disease going on that needs to be addressed. That's actually more of an emergency. So it really so those are the biggest things: hypertension, heart failure. So let's take that one on. When someone has heart failure, depending upon the type of heart failure, they can get lower extremity edema, and then that swelling in your feet can put you at risk for infection. People with more advanced disease have so much swelling where they start having weeping out their skin. So another reason for that puts someone at risk for infection. All of these abnormalities put people at risk for falling and not being active. So, the body keeps the score. We want to stay as active as possible. So really looking at your feet is super important.
okay, thank you.
You're welcome.
Um, I want another question on pace, and there's a couple more in the chat too. I'll get to those folks. The pace you mentioned, dual eligibility
Hmm.
is the more common.
Hmm.
And Medicaid, I guess, would be number two. I'm guessing. I don't
Yeah.
know that. And then Medicare. So,
Mhm.
um, why isn't Medicare more prevalent in the PACE program as far as how it gets paid for? And then the other thing was, and I think you were very thorough in describing this, but I wanted to make sure everybody understands that once you're in a PACE program, you don't see other docs outside of that. Is that correct?
Well, it's coordinated care, but the physicians in the PACE program, your PCP, they become your primary care physician. So yes, That can be a hard transition. It is a capitated model, and all of that care is coordinated. It's not as if your other physician wouldn't um, learn through the communication that should occur about how a patient's doing. But the PACE program now is the one that writes your prescriptions, that orders the x-rays, that's transporting you to and from your appointment, that interacts with the physicians if you're in a nursing home. Every nursing home or facility has a medical director there as well. Interacts with the hospitalist, the subspecialist, if you are admitted to a hospital, which they're really trying to prevent with all that close care. To
Sure.
answer your question about why Medicare, I really there's probably layers to that answer that I don't know, to be honest. But what I think the reason why I think the Medicaid, Medicare dual eligibility may be more common is partly because of some of the health disparities where people are at risk for progressive chronic diseases, because they may not meet, especially with the Medicaid, they may not meet, or they don't meet the financial integrity to really take care of themselves. Those patients, anybody in that circumstance, is at risk of hospitalization. I mean, Medicare patients as well. So, um, I think there's fair representation in the Medicare, Medicaid, and then the dual eligibility of both. So I wouldn't exclude a Medicare patient at all. I think it really comes down to someone's functional status and cognitive status for
Mhm.
the PACE program, based on the eligibility criteria.
Okay. Yeah, thank you. Um, we have a question here. I'm a community service coordinator in Denver,
Hmm.
and I work at an independent living facility. It's low income.
Hmm.
Are the programs you've described today available to their residents?
Yes, they are.
Okay.
And I mean, we actually just hired an amazing lady that works in that type of environment. Those also run PACE programs, that has a lot of expertise in accessing patients in that environment to bring them the care. So yes.
Okay. Thank you. Um, you read off those goals of care questions earlier.
Yeah,
Is
I hope I did. I sounded like Dorothy the Downer, but um,
no, the reason
Debbie
I'm
the
asking.
Downer, I should say. But
No,
yeah.
I'm only asking because is that something we can get a copy of?
Oh, definitely. It is the best document, and I discovered that back in 2010, and it really speaks to all of us. Like, how do we want to live? And let's decide now while we have capacity, where we can think. Interestingly, though, there are what I've learned in my career is people that have chronic illnesses that are hospitalized a lot sort of get used to their new normal. So when they go into the hospital, we get them feeling better, we beef them up, and then they're discharged, not at their previous best self, but they start getting used to that functional decline and cognitive decline. But it's really important for all of us to think about these things, but also share it with our children or people that may be making decisions for ourselves, because it really takes the burden off of them. And then you have the right to choose, how you want to live. So I
Yeah.
can get that to you. It's easy. It's an email away.
Okay. All right. And then once we get that, we'll post it on our website too.
Yeah,
I think it's very important.
thank you.
And it reminds me of something I heard just recently in another talk, which was really stayed with me. Three things to talk to yourself about. I'm alive.
Hmm.
I will die. I don't know when.
Yeah.
Um, so because the I don't know when part is so important because that means get prepared. It's
Yeah.
um,
Well, for sure. And when I think back to the days when I was delivering babies,
mhm,
before, actually before I did my G1 in college, but even during my training, I still did um, my obstetrician role, is people come in with these elaborate, birth plans. And, but when as we season, it's so difficult for us to even think about that change, that unknown death. And I get it because I want to live as long as I can, as independent as I can. But it's really important for us to have a plan.
yeah, yes, and unfortunately, so many of us don't have one. So,
Yeah,
um,
yeah.
okay. I would ask the audience here, do you have any other questions for any of the folks on our panel today? Um, Before we go, though, I have one last question.
Okay.
You mentioned the capable, and when the nurses go in, and I think occupational therapists also,
Mhm.
um, and they do see that there's an issue with financial decision making or the ability to write checks or whatever. What happens then?
That's a great question. Um, I I wish I could tell you the answer. What I would hope is that that particular situation. I mean, the nurse I think is well schooled. Mary Beth, we don't have a social worker as part of that program, correct? Like, how would you answer that question as a nurse for the capable program? Because you've been here longer than I have.
Well, the evaluation is done, that's your team, right?
Yeah.
So it's the nurse, it's the occupational therapist, and it's the handyman. And all of their, assessments then make up the plan. And so it's just like any other team that you have working for you, whether it's your oncology team, your cardiology team, those professionals will go out. The nurse will do the assessment of your medications, of, she'll probably take a look at your feet. Um, what your nutritional status is, how are you doing health wise? While that is happening, and I can't tell you that they'll all three come out at the same time, because again, it's going to be these three evaluations. But then the occupational therapist comes in, looks at your rugs. Are they safe? Where do you need a grab bar? How are you being successful at your activities of daily living? And then based on the two professional clinical um, assessments, then the handyman comes in and says, yep, that bathroom isn't safe, and we're going to put some steps in the back so that you can do that gardening that you wanted to do. So it's this team approach, and those are your three team members, and it's coordinated based on your schedule and theirs.
What are the financial concerns that I think Bob was raising? My answer would be we'd send him to AgeWise for 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 your services to answer some of those questions. I will actually learn more about that next step because that's really important.
Yeah, it is very important. Yeah, as we all know, our there's a particular age group that gets targeted more than others for financial scams and
Hmm.
things. Um, this is kind of a side note, but I was just reading about this morning. Now, Cambodia has been renamed Scambodia. You know.
That's amazing. Well, it is scary. I'm afraid to even open an email at this point. And keep things on my phone, um, bank
Mhm.
accounts, things like that, because these people are smarter than me, and it's pervasive. And I worry about that. I worry about even cybersecurity issues in the healthcare system. Um, so I
Sure.
think we're unfortunately in a very uh, dangerous time with
Yes.
scams.
Yeah, we are. Okay. If there are no other questions, I don't have any more. And I want to thank all of you for participating with us today. And thank you, Dr. Keefe, for for your presentation. It's been very informative and helpful. And we'll see you next time, whenever next time
Yeah.
is. Okay.